Okay, are we back? And can you see chapter 4?
Yes.
Okay.
But the PowerPoint version, not the slide version.
Can you see introduction?
No, I still see chapter 4.
Oh, gosh, I did it again. New share. Can you see introduction now?
Yes.
Oh, okay, good. I have 3 of these things up on my screen. It's like, which one? Okay, let's talk about bacteria and the host response. This is what we're all about, my friends. The inflammatory and immunology fundamentals. Okay, this is going to overlap a lot of what your pathology course has. I don't know where you are in the early stages of this because we're at the beginning of the semester, but it's that immune response and how does the body respond to infection that determines what's going on in what we're seeing in the mouth. So it's the nature, excuse me, and duration of the inflammatory response that's critical to the clinical outcome. Okay, our clinical outcome for our patient is they come in, we make the assessment, we make up the dental hygiene diagnosis and the treatment plan, and we go through our recommended treatment. What is that clinical outcome? Are we restoring health? As in gingivitis, are we able to maintain what's going on in the patient's mouth? So it's the destruction that's influenced by the host's inflammatory and immune process. So we have two people, they might have the identical bacteria in their mouth, identical, but these 2 individuals their bodies are reacting very differently from the same setup. And that's that immune process and the host's inflammatory response. So if the inflammatory response of the host is sufficient to control the challenge of the plaque without destruction of the periodontal ligaments or the alveolar bone, they're going to be in a chronic gingivitis state. But if there's destruction of periodontal ligament and alveolar bone, if there's apical migration of the junctional epithelium, they have periodontitis. So there's something called periodontal disease activity, PDA, if you're into initials, but that's for periodontal disease activity. So chronic inflammatory periodontal disease state is an ongoing thing. If it's chronic, it's ongoing. The pathogenesis of periodontal diseases is the result of a complex interaction between the plaque microorganisms, okay, all of that phase 1, 2, 3, and 4 that we were looking at, and the host's response to the presence of those microorganisms on the tooth and the gingival tissue. How is that gum tissue, how is that body responding to that bacterial mass? So you have host cells that fight the infection. You have your PMNs, okay, your neutrophils, your macrophages, your lymphocytes that are all cells of the host immune response that are coming from the body. Once that equilibrium is out of balance, once that equilibrium is out of balance, the host mediates destruction of hard and soft tissue. Our body is the host. Failure to remove biofilm from the tooth and the gingival surfaces results in a chronic challenge to the host. Is that making sense? If you're leaving that biofilm there, You have a lot of activity going on, which is putting stress on the host, trying to fight that infection. So we have these different theories that are out, models of disease activity. One of them is the continuous model theory, which states that slow, constant progression of disease is going to occur. And it happens faster with age. So if you've got gingivitis, it's going to progress into periodontitis, and it's going to progress into tooth loss. Continuous model, it goes on slow and steady. Then there's the random burst theory, and that states that for a short time of active loss of attachment, okay, it bursts of activity. So there's intermittent periods where everything's kind of quiet and it's in remission, it just stays there. The other names are episode burst theory, site specific. Okay, it's site specific, and not all sites are equally susceptible. So the episode burst theory or the random burst theory is stating that you're going to have a short time of attachment loss and then a period of calm. Okay, and it's not the whole mouth. It can just be on tooth number 14 mesial. Continuous, slow and steady, random burst, just what it says. Asynchronous multiple burst theory. Activity occurs during limited time, followed by remission. Now, what's the difference between the asynchronous multiple burst theory and the random burst theory? I have no idea. But the current thought is that it's a combination of a little bit of everything. When I was a student, I graduated. If you had gingivitis and you didn't take care of that, you were going to have periodontal disease, bone loss, you were going to lose your teeth, and then you were going to die. I was guaranteeing every patient, if you didn't take care of this right now, it was going to progress. Well, we now know that it doesn't happen like that in everybody. We can have some patients with chronic gingivitis that does not go into bone loss for years and years. And other people are going to be more susceptible. Again, immune host response. So the host response varies between individuals, okay? And that explains the difference why the disease severity happens differently in one mouth than the other. Gingivitis may progress into periodontitis if the host resistance decreases. And there's a variety of environmental and systemic influences that can have an effect on the periodontium. We're talking stress, chemotherapy, steroids, also things like diabetes, high blood pressure. All right, so some people are going to be more susceptible to developing periodontitis than others. Immune host response. So the host susceptibility and bacterial activity need to be in balance to maintain homeostasis, where everything's in balance. So in order, okay, for gingivitis to develop, we have to have a decrease in the number of beneficial bacteria, because remember, we have up to 700 or more different species of bacteria. We're supposed to have bacteria in our mouth, okay? Some of them are good and some of them are bad. So there's that dysbiosis where there's a decrease in the beneficial bacteria and an increase in the pathological bacteria. And you have to have a favorable environment. Favorable environment, warm, dark, moist, it's a mouth, and undisturbed. That bacteria needs to be undisturbed, and that's that favorable environment. So when we're talking about plaque retentive tooth surfaces or plaque retentive surfaces like an overhanging restoration, that again is a favorable environment. And you have to have a susceptible host that reacts to the pathogen. So we've got this bacterial host challenge. Supragingivally, we know that you've got your gram-positive aerobic bacteria. That makes up healthy biofilm. You are gram-positive. All right, it doesn't start turning into gram-negative until it starts migrating subgingivally and it's being protected and not disrupted. Okay, then that gram-negative bacteria starts coming into play. So the bacteria in direct contact with that junctional epithelium has the potential to become pathogenic and cause disease. It's protected underneath the gum tissue. There are metabolic wastes and toxins, okay, because it's living bacteria. It has to eat, it feeds. If it eats, it has to have a waste product. It's got to poop, right? Okay, and we use those terms sometimes when we're talking to 3 and 4-year-olds about the bugs on the teeth, pooping on their teeth, causing cavities and eating a hole in their tooth. So you use language that the patient can understand. I would not use poop talking to an adult. Okay, they're waste products, but they are irritating to the host. So it's that host response that results in the inflammation. The host response. You've got gram-negative microorganisms that are underneath the gum tissue that's causing all the havoc. So you can see these are the gram-positive right at the gingival margin, but as things migrate subgingivally, it's turning into a gram-negative anaerobic. All sorts of stuff going on. Do you need to know this? Absolutely not. But this is just showing you what's going on with this bacteria, okay? And there's this word cytokine we're going to get into. So there's all sorts of stuff going on. You have endotoxins, which are lipopolysaccharides, and they're part of that outer gram-negative membrane that's released when the cell dies. You have an endotoxin. It dies, it's got waste products. You've got a leukotoxin, and that's an exotoxin which can kill these neutrophils, these PMNs. You have waste products, ammonia, hydrogen sulfide, that rotten egg perio smell. Sometimes you can smell the perio breath before the patient even enters the reception room. You have enzymes, hyaluronidase, okay? Anything ASE is an enzyme, and that breaks down the cement between the cells. Then you have your MMPs, your matrix metalloproteinases, MMPs, and they cleave components of that extracellular matrix. So you have bad stuff going on. Your lipopolysaccharides, okay, are released when the cell dies. Your leukotoxin, okay, are exotoxins that can kill your PMNs. Those are being released. You have waste products. You have enzymes that eat away at things. So the host and bacterial cells release these enzymes, which actually prepare the gingival tissue for adsorption of the toxic products. Okay, this is all part of our defense system. So the host interacts with these microorganisms in 3 different areas of the periodontium. We have our supragingival environment, the gingival crevice, and then the gingival connective tissue. We have control over what we can do with the supragingival environment. That's our brushing and our flossing, and then the gingival crevice and underneath, okay, is our flossing, our Bass technique of brushing, which we're going to get into, maybe our water picking and our irrigation, and then the gingival connective tissue, okay, and that acts as our barrier. So we have our oral epithelium, okay, our oral defense mechanisms here. We've got our oral epithelium. Our saliva helps wash things away. Our gingival crevicular fluid, all right, is a defense mechanism as well. It increases flow when there is inflammation, bringing our PMNs and everything. We have cellular shedding going on. Let's get rid of the dead stuff, okay? And our oral epithelium, which acts as a barrier. So we've got a lot of defense mechanisms going on inside the mouth. So our saliva has antibacterial factors as well as antibodies in it. Our gingival crevicular fluid is an outward flow to cleanse the sulcus. Now, it's very minimal in health, but the volume increases during the inflammatory process. And that's the takeaway there. It increases with inflammation. You have your oral epithelium that prevents bacteria and their byproducts from entering the underlying tissues. All right, we've got our surface keratin and those close attachment to the cells. You have your shedding of the epithelium cells from the oral mucosa. All of these are protective mechanisms. But we have an inflammatory response that's going on. It's a non-specific response. Our body doesn't know, that, oh, this is gum disease versus this is a splinter in a finger. All right, it's a non-specific response to prevent the spread of invading bacteria and to destroy the agents. All right, our body responds the same way. It's activated by antigens passing through the PMNs, okay, our white blood cells defense. It's making it past that and through the junctional epithelium. That results in the elimination and slowing down of the invader. It's limited, again, by further tissue destruction, and then you can begin healing. If the body can take care of itself with the bacterial load, you're going to be able to maintain homeostasis. So as the protective wall of the neutrophils between the biofilm mass and the gingival crevice and the junctional epithelium becomes compromised with that bacteria and the endotoxins, the inflammatory response becomes magnified by the immune system. Once the antigens in the pocket pass through the wall of the white blood cells, which is the first line of defense, once the antigens pass through that and touch and penetrate the connective tissue, you have a burst of immunological responses that results in the gingival tissue damage, as well as alveolar and supporting bone destruction. So that's periodontal disease. So we've got our tooth surface here, our gingival sulcus, our PMNs, our first line of defense, okay, and overgrowth of bacterial biofilm is here, all right, and then it's trying to invade subgingivally, passes through those PMNs, and then you've got more destruction going on. All of that is happening when you see inflammation. All sorts of stuff is going on underneath the tissue that you can't see. It's very active. So we were talking about phases of biofilm accumulation. You've got phases of the inflammatory response, phase 1, phase 2, phase 3. Phase 1 is acute transient phase. That's the local vasodilation and increase in capillary permeability. All right, so this is everything swelling. All right, the spaces between the cells are starting to expand. Phase 2 is delayed subacute phase, and that's the migration of PMNs and other phagocytic cells. Okay, so first you've got permeability, then you've got those PMNs, the first line of defense coming in. Then phase 3 is the chronic phase, which is tissue destruction. And all of that can take place 72 hours to 3 days. Doesn't take long. So the first inflammatory response is vasodilation. Okay, and that results in an outflow of blood, fluids, proteins, and your cells, your PMNs. Vasodilation brings increased gingival crevicular fluid and those first line of defense. Substances responsible for vasodilation include histamine and prostaglandins. You need to know those words, histamine and prostaglandins. Now, histamine is released from the mast cells in the connective tissue. You're going to get more into mast cells when you get into pathology, but it's just a certain type of cell that releases histamine. Then you have prostaglandins, and those are fatty acids found in the cell membranes that are responsible for pain and bone loss in periodontal tissues. Prostaglandins, fatty acids, pain, and bone loss. Your gingival crevicular fluid flow increases. You have gingival bleeding. You've got bleeding on probing that comes from that lamina propria, the connective tissue, which is engorged with blood because of the disease process. Or you're a novice student and you're poking, right? With the periodontal probe, you're placing too much pressure on the probe. What is trivia? What's the amount of pressure the probe should be having in grams?
20.
10 to 20, exactly. So the inflammatory process, you've got vasodilation, which clinically shows as gingival edema and redness, erythema. So when you are doing your gingival description, we don't want to just see coral pink, red. We want, describe the papilla, papillary edema, marginal edema. Does it go around the margin, or is it diffuse edema? Does it go all the way down? Is it localized? Is it generalized? If it's localized, we want you to tell us, where is it localized? Mandibular anterior? Okay. So again, prostaglandins are fatty acids produced by the body, in the body by initiation of an inflammatory response involving the release of substances from the injured cell membranes of the tissue, followed by the production of prostaglandins. And then prostaglandins are involved in the entire body process. It's an inflammatory response. This is something that your OHE books are going to have. Everybody's going to probably have some form of the oral systemic link, okay? And this is just one of the many that you can find. Bacteria from the mouth enter the bloodstream through the gums, and it can cause damage in all sorts of other organs. So let's get into this neutrophil. The neutrophil is a major phagocytic cell. It's referred to as the first line of defense. You've heard me say that. These are the first cells that migrate to the gingival crevice and junctional epithelium in response to chemotactic substances. Chemotactic, those are toxins and bacteria. They are sending out signals. This bacteria, all right, sends out signals. These neutrophils have a very short life of only about 5 days. You need to know that. First line of defense, short lifespan. Chemotaxis is the movement of cells in the direction of a chemical attractant. So the inflammation is giving out chemical signals to say, hey, there's something going on. So you've got these neutrophils coming in to try and fight that infection. They're talking to each other. You have endocytosis. Okay, that is once the once it's at the site of injury, the bacteria are engulfed by the PMNs. Remember, they are a phagocytic cell. They engulf and ingest solids such as bacteria. Engulf solids, okay? Exocytosis is as the bacteria are consumed, you have these enzymes that leak out of the cell, causing destruction of the host cell. Okay, so they're byproducts. It's not the bacteria itself, it's the exotoxins. They're byproducts. PMNs, the first line of defense that migrate to the infection site. Who remembers how long they live?
5 days.
5 days, short acting, 5 days, yep. Neutrophils comprise more than 90% of the circulating granulocytes and move by chemotaxis. And you need to know chemotaxis. Chemical signaling. So the neutrophil, first line of defense. Then you have your macrophages. These are other phagocytic cells. Monocytes change into macrophages and migrate from the blood vessel to the inflamed connective tissue, again by chemotaxis. These live longer, okay? They don't come out like the neutrophils. They're not the first line of defense, but they remain in the connective tissue for months and clean up the body's damaged tissue while also secreting prostaglandins and cytokines. Now, cytokines, all right, are also signals. Prostaglandins are responsible, again, for bone destruction and pain. Cytokines are proteins that regulate the activity of the cell. Okay, they regulate the activity that releases them as well as other cells. Now, there's something called interleukin-1 and tumor necrosis factor. We're going to be talking more about the interleukin-1 than the TNF, but both of these are involved in the inflammatory process. They increase the number of osteoclasts, stimulating bone resorption, okay, and that's what periodontal disease is, osteoclasts, and they're less potent. It's a less potent stimulator of bone resorption. But they're low and slow. It's going to happen. A macrophage is a phagocyte that ingests foreign material. Your neutrophil is considered a macrophage, okay? A phagocytic cell that only lasts for about 5 days, and then the other macrophages come in. So a cytokine is a signaling pathway. They communicate with each other through cytokines. They communicate with each other. There's something called opsonization, and you need to know this, okay, as well as the complement system. You got to know this. These are board questions too. Opsonization. They are opsonins that are antibodies that bind to the surface of the bacteria, coating it, making it easier to be identified by the PMNs, so it makes phagocytosis more effective. So opsonization is a coating of the bacteria that helps signal those PMNs. Yoo-hoo, I'm bad. I've got this raincoat on. Come and get me. Opsonization. Phagocytosis is more effective if opsonins are present. They bind or coat the bacteria, making them easier to be identified so that they can be engulfed. And you've got your complement system, and that is comprised of about 20 to 30 different plasma proteins. They destroy invaders and they lysis or break apart the bacteria. It generates chemotactic factors, attracts the PMNs and those macrophages and the disease fighting bacteria through something called a classic pathway. And that's activated when antibodies bind to the surface of the bacteria. So the complement system is, again, a way for the body to communicate that infection is going on. There's an alternative pathway with endotoxins that activate the system. Then there's also something called a third pathway that involves the binding of specific proteins to proteins or carbohydrates on the bacteria. But you need to know what the complement system is. So if inflammation doesn't subside within 7 days, it's going to become more of a chronic reaction. We're talking about the body's response, okay, inflammatory response. There's a specific host response that's next in line that states that it recognizes the antigen and communicates with other cells to destroy the antigen. So there's a lot, again, of talking going on. So there's two parts to the immune reaction. You've got your humoral and your cellular immunity. Have you been in this yet with pathology?
Not yet.
Not yet. You're going to be getting this. Okay, so it won't be the first time you hear it when you have Mrs. Heberly. So we've got major cells of the immune system that are white blood cells, and they're called lymphocytes. They go around and patrol the body, identifying foreign pathogens, and they eliminate them. Your lymphocytes originate in the bone marrow and travel to other areas of the body. So you've got your T cells and your B cells. Your T cells are mediators of cellular immunity, and your B cells are mediators of humoral immunity. This is what it looks like. So in periodontal infections, you've got toxins and enzymes that enter the lamina propria or your connective tissue, and then the inflammatory immune response is set off. You have antigens that are carried to the lymph nodes by the macrophages, and you have B cells that transform into plasma memory cells. B as in boy, B cells. All right, so you've got cell-mediated immunity, antigen-bearing cells, destruction by T cells, humoral, okay? Humoral immunity uses antibodies produced by B cells. Now, what are we talking about when we're talking periodontal disease? Okay, plasma cells make antibodies with T helper cells, and circulate in the body to destroy the antigens. Antibodies float through the body. They're just waiting for invaders. They're just floating around, and they lock onto antigens and neutralize the enemy and tags it for an attack. Macrophages then can phagocytize and digest the debris and stimulate the repair. So that's humoral immunity. Humoral immunity is activated in severe gingivitis and periodontitis. The proportion of B cells in connective tissue at the sites of periodontitis can be as high as 90%. B cells as high as 90% trying to fight infection. B cells, B as in boy, humoral immunity. T cells mature in the thymus, T cell thymus gland, and they migrate into the bloodstream and the lymph nodes. You have two different types of T cells, T helper cells and cytotoxic T cells, which are killer T cells. Don't die here, folks. Don't freak out. You're going to be getting this again in histology. This is more, or not histology, I'm sorry, in pathology, and you're going to need to know it more for pathology than you do for perio. But look at this, the CD4 receptor secretes cytokines, those chemical agents that talk to each other, that activate the phagocytic cells. CD8 receptors, okay, directly kill viruses and cancer cells, parasites, and other bacteria. Both have protein receptors on their surface, plasma membranes. Now, I don't know if you remember what the medical consult form had. One of them was the CD4 count, reduction of the CD4 cells in AIDS patients. So we want to make sure if we have somebody with AIDS, we want to know that they have enough of these CD4s to actually fight the bacteremia that we're going to be causing. Cellular immunity is the most effective against virus, fungi, cancer, and foreign cells. It does not play a major role in periodontal disease. Cellular immunity is more for other infections. Humoral immunity is associated with periodontal disease. So you've got humoral immunity, cellular immunity. Both are infection fighters. Which one is more prevalent or is linked to periodontal disease?
Humoral?
Humoral is activated, yes. Humoral immunity, the big takeaway, humoral immunity. Okay, what species are predominant in supragingival tooth-associated attached plaque? Supragingival, okay, what are the good guys?
Gram-positive rods and cocci.
You want gram-positive, so you're looking at the gram-positive, right? And the filaments aren't really the good guys. So rods and cocci, excuse me. Page 59. Gingivitis may progress into periodontitis if the host resistance decreases. That's a yes or a no. Some reasons for a decrease in host resistance include stress, chemotherapy, leukemia, and steroids. Gingivitis may progress into periodontitis if the host resistance decreases, absolutely. Okay, and then the listing of the decreases were all true. How long does it take for the inflammation of the gingiva to be seen in the mouth? To be seen?
72 hours.
For some, it's fast. For others, it's slow. You've got patients that will only be brushing once a day or once every other day. They never floss, and it's 5 years since their last cleaning, and darn, they look good. Immune host response, there you go. If the dental biofilm is allowed to accumulate at the gingival margin and is not disrupted, inflammation or gingivitis can occur within 72 hours. A blank in the blood differentiates or changes into a macrophage and migrates from the blood vessel into the inflamed connective tissue by chemotaxis. What is in the blood? Now, opsonin, remember, is that raincoat. Opsonization is the raincoat. So it is going to be a monocyte. A melanocyte gives color, We know it's not opsonization. We know it's not a melanocyte. So it's either a lymphocyte or a monocyte were your two choices that you had to choose from. Okay, page 64. Periodontal diseases is involved in what kind of immunity?
D.
D, humoral. Yes. Okay. Guess what, folks? We've done chapters 3 and 4. Are there any questions? Okay, this is heavy material, so take some time to digest it. And after you read the chapter, go through it. It's not going to sound so foreign, but after you look at the chapter, then you can attempt the quiz. Okay, thank you for accommodating our schedule and coming at 8 o'clock. Aren't you glad you didn't have to travel to campus? You could just kind of roll out of bed and get here. I like that.
Yes.
Yes. Okay. All right, my friends. I hope you enjoy the rest of your day. Miss McGraw is going to be on. What time is she starting? 10:30?
11.
Oh, 11. Okay. Well, you've got a little bit of a break. Thank you. I am an email away. Please email me a second time if I'm not responding to you. Please harass me. Okay, guys, that's it. Bye for now.
Hi, thanks.
Thank you.
You.